Annual meeting. Was anyone here for day one? Yes, raise your hand. Awesome. Okay, great. So this is not going to be a surprise that we're going to ask you once again, if you have not yet, to please download the mobile app. So it's more than just a little fancy tool. So if you have your mobile app on your phone, this is the one time where you're not going to get in trouble for looking at your phone, right? Okay, so the reason that we're doing this is because we have some interactive tools. And first, we're going to just actually ask you to just give your attention to our director, Dr. Dalpan, for a welcome, and then we'll go through more of the tools of how to actually download the app so you can use it.
All right, so good morning and welcome to day 2 of the Sentinel annual meeting. It's nice to see a packed room here. And I imagine many of you, perhaps most of you, attended day 1, and perhaps some of you have attended both day 1 and day 2 in previous years as well. But don't worry, this will build on that. It won't be unnecessary replication. So if you were with us yesterday, I think you heard how the Sentinel system has really continued to grow. It's evolved. Its capabilities, both in terms of the data and the analytic tools, continue to evolve and grow to meet a widening set of needs in terms of drug safety and the kinds of questions we're asking. We're able now to really answer questions that we couldn't have years ago, and that's been really helpful to us. So just to recap what the sequence of days is, yesterday was perspectives from FDA leadership and the Sentinel Operations Center, as well as the people involved in BEST. And NEST as well, and then updates on growth and ongoing development of Sentinel. So you heard about a lot of the new features that we've put into Sentinel over the past year and that we plan to add to Sentinel this year. So today's day 2, that's the focus right now. That's how to use a Sentinel analysis tools to answer medical product safety questions. So this will be a much more technical meeting than yesterday, which was really more at the programmatic level, and how to assemble a full CIDA query package. CIDA is cohort identification and analysis. And then tomorrow will be for our international regulators, and I see some of them here today, but I want to welcome everybody. Let me give a plug again for the app. I was really surprised and happy to know that we had an app. It may be the first app for an FDA meeting. I'm not sure. I don't want to make that claim, but it I think is a great development. So I'm going to turn it back over to the meeting organizers, and I wish you all a good meeting and a good day. And thank you for coming.
Okay. Okay, so this slide, once again, I also want to welcome all those who are watching online. I think we have a number of people who are chiming in via webcast, so I want to welcome you as well. We appreciate all of your input. And yes, if you can, especially if you're watching via webcast, the ability to download the app is going to also allow you to integrate a little more fully into today's meeting. And we also have several notifications that we're pushing out. You have the ability to check into the sessions. And so we'll leave that up a little later, but for now, I just want to give you a quick walkthrough of the app so that you know exactly how to use it so you can maximize your experience online. So the block that you just saw, let me actually go back. As you know, whenever you download an app, it's not super science, not rocket science, but those just gives you an opportunity to go through the agenda. Sorry. Okay, so now that you're inside, once you get in, this is what you'll see. And this first one is the refresh. This is really important because throughout the day, as we continue to do different downloads and uploads and notifications, you want to refresh it. It'll show you every time when you have a refresh that's available. Also, agenda and polling. So throughout the day, as you know, we have 2 tracks. One is for non-programmers, and we'll be leading that session in this room. And we also have a session for programmers that'll be led in the adjacent room to our left, or to my left and your right. We also will have some polls and some surveys there, so that way we can get your feedback. We want to make sure that this meeting is continually meeting your needs and that we're addressing to the things that you, the questions that you have and the things that you need. Also, you'll have an opportunity to see the speakers and the presenters. as well as important documents. So we have actually broken this particular segment out. So we have important documents for day 2. So even if you want to go back and reference documents from day 1, if you were not here, you have that opportunity to do so. And you also have the opportunity to see documents that are important for today. So now I'm going to walk you through, once you get inside, this looks very similar to what I just showed you, but once again, you get to see that refresh button and also the agenda and polling. I'm just going to use this as an example of what it will look like. You'll open up and you'll see today's agenda. As you drill down, if you go into the introduction, you'll also see the speaker. And you also have an opportunity to do discussion. So the key point with this is if you have a question and we're not able to answer it from the floor, you don't have an opportunity to ask it for whatever reason, you can drop it into the discussion section. We'll be actually monitoring this piece so we can make sure that we're addressing all of your questions and that the speaker has an opportunity to speak to them, if not immediately, at some point throughout the meeting. And it looks just like this, just like your social media. Who's on social media? We're not going to check. We just want to know. This is where you go into your discussion. And so you also have an opportunity to see that survey once again that we have posted. And you can also add this to your schedule, which is really key. So let me see if I can push through. So now, I know this is the big question. Everybody wants to know, where's my information going? Who's going to see it? What's the access? So we made a special sheet just to let you guys know. So who will see your data? Actually, this data that you provide as feedback, the only people who will actually see that data are FDA administrators, as well as those who are helping us with the actual guidebook. So you don't have to worry about any infringement, no firewalls, anything like that. Also, who will have access to the, let's see, who else has access to the data? Like I said, no one will ever see your data. Will that data be deleted? Yes. Actually, 7 days after this meeting, whatever feedback you provide, we'll have extracted that from the app, and you don't have to worry about it just sitting out on the cloud. Also, can others who use the mobile app view anyone's responses? No. Everything that you provide to FDA will be private. Yes, other people can see the questions and they can go in at any time. So even if you feel like you can't stay to the end of the meeting, we really, really appreciate your feedback. And so this kind of helps us, like I said, make our meetings more robust, more complete. And so we just want to be able to take that information and be able to bring you an even better meeting next year, as if that could actually happen, right? This year is amazing. Now, so these are things you also probably really want to know. When are we going to eat? How you get to eat? When you came in, you see that there's a kiosk on the outside. You may want to make sure that you're able to go in and do a pre-order, because I'm not sure if you have the opportunity. You can leave if you want, but it's only an hour for lunch. So we wanted to make this accessible to you. So if you have an opportunity to go out and pre-order your lunch, I would do so probably actually before 9:30. It says 10, but I would probably shoot a little closer to 9:30. And the cost is $11. You can use cash or card. And lastly, for Wi-Fi, this is also on the mobile app. As soon as you open up, it's on the home page, and it'll show you the network and also the password to access it. Has everyone been able to access, or anyone having trouble? If so, we can help you outside. And if you're online and you have questions, please feel free to drop them in the chat box in Adobe, and we'll be able to answer your questions. And with that, I have the awesome privilege of introducing our incumbent, Judy Morrow from Harvard Pilgrim Institute. And so she's going to come and start today's session, review of Sentinel capabilities. Thank you so much for your time. And again, if you're online, we appreciate your time.
Thank you, Anissa. Hi, everybody. Good morning. I recognize many people in the audience, and I'm thrilled to see many friendly faces. So for folks who may not know me, my name is Judy. I am at Harvard Pilgrim Healthcare Institute. I'm an assistant professor there, and I'm also the Sentinel Operations Center program lead. And so we're going to be talking this morning about Sentinel capabilities. That's going to be our starting point. For many of you, this information might be review. But for others who maybe are less familiar with our program, we wanted to make sure we go through this as sort of the basics before we get started. And so we're going to lead off with that, and then we'll get started with thinking about a medical product question of interest, and then walking through that whole process. So without further ado, we'll go with a review of the Sentinel capabilities in the program. So this is an infographic that we have on our website, and it's designed to help explain what the Sentinel system is. And so I want to draw your attention to the left portion of the screen where it talks about sort of the key components of the Sentinel system. And the first one is about information, or what we think of as data. And so I see several of our data partners in the audience, and it goes without saying that the foundation of the Sentinel system is based on having data available to use by the FDA to answer regulatory questions of interest. Along with that data comes experts that help us to utilize that data. And those experts are located not only at the data partners themselves, who have the best sort of understanding of how that data is gathered, what are the limitations of those data, what are the strengths of those data, but also we have a network of academic experts from pharmacoepidemiology, from biostatistics, from data science and other sorts of machine learning and natural language processing, and those experts also help us to make best use of these data. And finally, the other component of this is creation of computer programs, which is what we're going to be doing today in session B in the afternoon, which are SAS packages that essentially allow us to ask standard medical product regulatory questions of interest. And so that combination, we sometimes also refer to those as our tools. And you'll hear me throughout the day refer to the routine querying tools, or the CIDA tool, which stands for the Cohort Identification and Descriptive Analysis tool. All of that is sort of the components of the program are the data itself, the tools to access those data, and the expertise that is needed to actually understand the data and the tools. And so all of these components combine together to help the FDA to answer regulatory questions on behalf of the public. So some of our expert network includes our collaborating organizations. And so at the Sentinel Operations Center is located at the Harvard Pilgrim Healthcare Institute, where I am. Then we have a group of folks who are what we think of as our data and scientific partners. And so you can see some of their logos here. And then we have the folks that I was talking about, the academic partners, who we call on for particular expertise in scientific areas of interest. And so this is a slide that was also shown on day one, but just to understand who's in our network and who we utilize to help us answer these questions. So we're going to go through the Sentinel infrastructure and the available data elements. Again, this may be review for some folks, but I want to make sure everybody's familiar with it before we talk through the rest of the day. So I'll start with the Sentinel data philosophy. So the Sentinel data model includes data from claims, from electronic health records, from registries, and it's flexible enough to accommodate new data domains, which come into play as the FDA authorizes their inclusion in the Sentinel Common Data Model. Typically in the data model, we try to be as parsimonious as possible. So we don't have empty tables. We try to make sure that every data element we're collecting is utilized, and we expand as needed in a fit-for-purpose way. The data themselves, we try to have them stored at the most granular or raw level possible with minimal mapping. So basically what we would like is to have as little lost in translation as possible. We, in that vein, attempt to keep distinct data types separate. So for example, we can have from certain of our data partners, our electronic health record data partners, prescription information. That's a different data stream than dispensing information that comes from the pharmacy. And we strive to keep those separate and unique so we can access them as needed for the purposes that they particularly serve. What we do when we keep all of that data in the raw form is we use the analytic tools, the routine querying tools, to construct medical outcomes of interest, or sometimes people think of them as computable phenotypes. So basically what we're doing is we're putting together those different data elements using Boolean logic in order to come up with a concept, a clinical concept, that then we utilize in project-specific design choices. And we store these algorithms and the way that we utilize them in a library so that we can then access them for future use. So one of the things that I had touched upon before, but I'd like to say again, is that we always call on the data partners themselves for their expertise in the use and interpretation of the data. So oftentimes we are running a query, we are asking a medical product question of interest, and we have thoughts about how these data have been collected and under what circumstances. And one of the things about having local expertise and having these data partners is we can always call them and ask them more questions and get to the experts to make sure that we understand fully those data. And as a result of that, each data partner has a slightly different configuration of data, and that site specificity is allowed based on what they can contribute. The idea behind all of the data model is that it's really designed to meet FDA's needs for analytic flexibility so that they can ask any combination of questions they want, for transparency so that we document everything, and for their own control over the question of interest. So here are the available data elements. So if you look in the upper left-hand corner of this screen, you're going to see what we think of as our core tables in our Sentinel Common Data Model. So these are tables that are populated by almost every partner. They include information on patient demographics, their enrollment information, which allows us to understand what kind of capture we have for people longitudinally. It has dispensing information. It has medical encounter information, which then is further broken down into procedures of interest and diagnoses of interest. As you move to the right, some of our data partners are able, especially our electronic health record partners, are able to populate clinical data, so some lab results and vital signs. Coming down to the lower left corner, we have registry data. So we have death data that comes from linkage to state-based death registries in certain cases for certain data partners, which then include also cause of death information. We also have some state vaccine registries. Moving over to the right, we have some inpatient data sources, and in those inpatient data sources, we have more granular understanding of inpatient pharmacy and transfusion data. So in insurance data or claims-based data, oftentimes these things get rolled up. So essentially, for example, with inpatient pharmacy, on sort of a billing from a hospital, very minor sorts of uses of medication, so aspirin and things like that, they're not individually line items. But when you have an inpatient pharmacy stream, then all that information is captured. And so that's sort of the difference here. And finally, our newest data table that we've added is the mother-infant linkage table. And so for folks who were here for day one, I'm sure that you heard a lot of information about this. So this is our newest data table. It allows us to link mothers and babies so that we can use that information to look for birth outcomes following in utero exposure to medications. So typically this linkage is done using subscriber IDs, but there also is some birth certificate linkage in there. So this is an example of what one patient might look like in the data model. So you see up in the upper left-hand corner, I have a middle-aged woman. She has associated with her category for her race classification, for zip code. She had an inpatient encounter reading left to right. That stands for that IP is an inpatient encounter. She was admitted to the hospital on October 18th, 2005. She was discharged on October 20th. During that stay, she had a number of diagnoses, which you can see as you move your eyes down to the diagnosis table, and she had some procedures during that inpatient stay. Some information on the left about her dispensings. There's indications that she was picking up dispensings at the pharmacy for medications prior to her inpatient hospital stay, and then medications that were after her inpatient hospital stay. There's information there about her enrollment period, so when we can think that we have complete capture of her information in the data model, and then in this case there is a record for death and a cause of death. And there, what it would indicate is the source and the confidence means where was that death record attained from? And in this case, it's sourced to a state-based death registry, and our confidence in that record is excellent. That's what the E stands for. And so essentially, this is what one patient might look like. And so what you think of is this is one patient's data. So take that and multiply it for the number of patients in each site. And then think about the fact that we have 18 data partners, each with their own sites for these data. And so it's really important to us when these data are curated that we go through a very rigorous procedure to ensure that the data actually reflect what we think is the experience that the patient has had. And so what we do with each of these data partners as they create these translated data sets in the common data model is we send them programs. So these are very similar to what we're going to do later this afternoon, but for a different purpose. They're SAS-based programs that query those data and check it to ensure that it is meeting the standards that we have for it to be included in the data model and to be utilized by the FDA to answer regulatory questions of interest. And so when we check that data, we have a series of checks, which I'll talk about in a minute, that help us to ensure that the data are fit for purpose. when we receive information back from the data partners that indicate that they've run this program and that they have results, we check those results. And then if we believe that those results are within standards that we've set, we allow that data to enter into the common data model formally and to be utilized by the FDA to answer the regulatory questions of interest. And so the types of checks that we do, the very first one is looking within each table for sort of general model compliance. So this is things like, for example, you saw in that example patient, there's a lot of information about dates. So we expect that all those dates are formatted so that they can be read in as dates. We expect that certain things are numbers and that we receive a number. So these are very basic checks just to ensure that the model is compliant. The second level of checks looks at how the tables relate to each other for the same patient. So we want to see that if there's a record in what we think of as our encounter table, that there are procedures and diagnoses that match that record information in terms of timeline, so that we can check that across tables that the information is consistent. Now, our third level of check has to do with the fact that we have these data partners who have been with us for 10 plus years, and they refresh their data. And what that means is essentially they overwrite their entire database and add new data on either a quarterly or an annual basis. And when they do that, we look at that information across time and check, did the last version of their data match this new version, and the new pieces, the new elements that they've added are consistent. And so when we look for that cross-time consistency, we're looking to ensure that there's nothing unusual happening. We don't see a large change in the number of records. We don't see a large drop in the number of patients. Now, sometimes, actually, those changes are explainable. So we have a lot of our data partners who are insurance companies, and they may acquire, for example, new groups of patients, new plans that come in, and then we actually do expect to see increases in the total number of patients in the data model. But we try to ensure that we understand that ahead of time, and we're anticipating that when we do these cross data set checks. And finally, our last checks are more logic-based checks. We want to ensure, for example, what we see evidence of pregnancy in women and not in men. We want to ensure that things that are just logically supposed to happen in terms of clinical experience, that's what we're seeing. And so, as I mentioned, some of our data partners have been with us for 10 years, and so as they have added data to the database, we've seen the growth of the Sentinel distributed database over time. So right now we have 70 million members that are currently accruing new data. You can see important points in here in sort of the Sentinel distributed database's life cycle, if you would, when we sort of continue to increase patient IDs over time. Our latest big increase in patient IDs came from adding a new data stream. We added the Centers for Medicare and Medicaid Services data in early 2018, and that caused obviously a large increase in the number of patients that were covered in the data set because that is a very large database. So in addition to our curation of the data in the Sentinel distributed database, which comes from our data partners, we also offer a mechanism to transform commercially available data. So many of you folks may be familiar with the IBM MarketScan research databases. It's a commercial service that you can purchase. And so we have created already a translation code from the MarketScan database to the Sentinel Common Data Model. IBM has graciously agreed to allow us to make that available to licensed holders of these databases. So essentially, if you're interested in utilizing the data tool, so backing up a little bit, why might you want to even convert your data at all? So what happens is that the querying tools that you'll learn about throughout today, those all work off the structure of the Sentinel Common Data Model. So having data that's formatted into the Sentinel Common Data Model essentially unlocks your toolkit, because now you have all of these pre-parameterized programs that you can execute against that data set. And so that actually opens up a huge window of opportunity to ask your own questions of interest, study questions. And so if you are a licensed holder of MarketScan, you can contact us, and then we can put you in contact with IBM, and then they verify your license, and then we're able to release the translation code to you. So I'm going to pause now and then say, so this is sort of the portion where we talked a little bit about the data. Now we're going to transition to the tools that actually, again, all work off that data. And so the tools are used to support multiple aims. So the routine querying tools not only allow us to ask safety questions of interest, which is contained in that Sentinel system box that you see on the left, but also the FDA Catalyst system, which you may have heard about yesterday, which is our system that we use the same tools, but the purpose of the FDA Catalyst system is really geared towards real-world evidence development and involves interactions with patients, which has to go through institutional review board processes, which is why it's sort of in a separate category. But I just want to make the point that the same querying tools are used for both purposes. So when we actually, how sort of the overall operation works, we've talked a lot about the data model, which you see represented in the upper left corner of this graphic. You see our 18 data partners represented there. So at the operations center, when we are ready to utilize one of our querying tools, we create this SAS package, which for folks who are going to stick around later today in session B, we'll be creating our own SAS package. We go ahead and then we send that through secure means to the data partner sites. At the data partner sites, they do minimal manipulation. Basically, they're pointing those packages to the right place in where they have the data stored that they have behind their firewalls. They execute those packages against those data. They review the results of those questions, and then they choose whether or not to send that data back to the operations center for aggregation and then processing in a report. And so that's sort of the process that we go through. So in doing this, every time we actually send a query out to our database, the data partners all actively opt into answering that query and then sending those results back to the operations center, which then results in us aggregating a report for the FDA. So what do we think of as our tools? So again, you're going to hear a couple of names for those today. The routine querying tools that support the active risk identification and analysis, or ARIA system. So walking you through from left to right are sort of different levels of the tools, but I want to first draw your attention to the bullets there, just to remind. These are standard SAS programs. They have been thoroughly vetted and QC'd. They are essentially templates for which you can ask a standard question. At execution, they are parameterized to your question of interest. So the asker is going to set the input parameters. They're going to say, what is the medical question they're interested in? What is the outcome of interest that they have? How are they going to specify this? And we'll talk through that today. And then there's standard output associated with each execution of these tools. So walking through here from left to right, we start out with tools that are being currently developed that are not yet fully available on the website, but are coming, which relate to signal identification. So this might be if I have a medical product of interest and I'm unclear about what outcomes I want to monitor, and I just want to monitor everything that's out there. Our current setup allows us to monitor about 8,000 outcomes simultaneously, and so this is when we don't have a pre-specified hypothesis about an exposure and an outcome of interest together. Now, other types of tools, the summary tables, those are tools where I'm looking for, is this medical product exposure or outcome of interest even in my database at all? This is more of a yes-no question. Does it have a presence or does it have an absence in my database? So it's very simple, it's very quick. It's just designed to bring back the very basic level of information. Then we move to what we think of as our level 1 tools. So these are very large-scale descriptive analyses of particular medical product exposures of interest or outcomes of interest. And what that gives us is incidence rates, which are unadjusted, but which have a lot of detail and information about the cohorts themselves and the study design. So the level 1 tools are primarily used to set up potentially for sample size calculations and other sorts of feasibility analyses that then may feed into what we think of as the level 2 or the 3. Level 2 and level 3 are inferential analyses. And so these are ones that are designed to produce risk estimates. They either are producing hazard ratios or risk ratios, and they're designed to sort of have a comparison going on between a treatment group of interest and a comparator group of interest in most cases. If they're done one time, we think of it as a level 2 because it's a one-time analysis. If we do them sequentially, so if we prospectively look forward and we keep performing the same test over and over again, then we're doing sequential hypothesis testing, and that's level 3. And so that's sort of our arc from start to finish of sort of the most basic type of query all the way through to the most advanced type of query. And so we have this other graphic that I encourage you to look at. It's available on our website to sort of help you think through what is the thing that you are investigating. And so the sort of the highest level piece is, am I looking for medical product data only in the absence of a particular outcome of interest? I just want to understand some utilization information. Am I looking for outcomes only in the absence of a medical product exposure of interest? So I just want to look at the rate of outcomes in a particular population. Or am I looking for information on the combination of outcomes following a particular medical product exposure? So each of those sort of starting points is going to lead you down a different part of this diagram to a different part of the tool that helps to ask that question. And so we're going to walk through some examples here. So the first example that we're going to talk through today is a medical product utilization query. This is just a straight query that helps to explain how a particular medical product is utilized in our database. So it follows individual patients when they have a valid exposure episode for the duration of information that we have in the database. And it's going to provide us information on the number of continuous treatment episodes. So that it's for folks who are taking a drug, if they go and they pick up their drug at the pharmacy and then they get a refill and they get a refill and they get a refill, if we string those all together to create a continuous treatment episode, this is going to count them. And it's going to count the time that happens in between those episodes. So if they have a gap in their treatment, so say they stop using a particular medical product for 6 months and then they start again, we'll see that information here. And so we utilize that to look at just basic treatment patterns amongst folks in the distributed database. So we have some examples of that posted on the website that you could see. These are questions that have very recently been asked by the Food and Drug Administration. We have a commitment to continue to post these as soon as we can, as soon as they are cleared, and so that people can see what kinds of questions is the FDA asking. What are the things they're concerned with? And so here is a utilization query related to particular obesity drugs. You can see the list of the medical products there, and you can check out this query at your leisure to see what the outputs look like and what kind of information we have in the database. So the next type of question is also a utilization question, but might be very particular because we're looking here at utilization among pregnant women. So here first we're looking for evidence of a pregnancy episode, and then once, which we confirm by finding a live birth first, and then backtrack to basically conclude that they were pregnant during a particular period of time. Then we're going to look for medical product use during that period of pregnancy. And then we also put out a comparator group of women who don't have evidence of a live birth, because we might want to understand how that medical product is used in women who we believe are not pregnant at that time. And so that is going to give us some metrics and information about the use during pregnancy and stratify it by trimester. We have a recent query that we have published. You might have seen this referenced in the slide deck yesterday. If people went to day one, there was concern based on a clinical trial that was done in Europe about off-label use of PDE5 inhibitors and the potential for them to cause neonatal death. And so there was concern that FDA essentially called us and said, what do we have in the database? What does our information look like? And so we ran this query. We posted these these results to the website, and you can see them here. The bottom line is there's very little off-label use in the United States. And so this provided some reassurance of what the scope was of use during that period. So some other types of questions we might ask, which was also discussed yesterday, are information about switching patterns. So there's concerns about folks who are switching from a branded product to a generic product, sort of what their pattern of behavior is, how quickly they switch, if they're switching from one generic manufacturer to another generic manufacturer. This type of question is designed to answer that, to describe that treatment pathway. So it's looking to describe if I switch from medical product A to B, where A and B are both the same product, but one is a brand version and one is a generic version. And so we have a couple of results on the website where this was from our first use of this tool, and these are related to concerns about, and this was also presented yesterday, about what happened when generics came on the market with respect to how they were utilized. So If I'm thinking about outcomes now, and I'm thinking about outcomes, again, without respect to a particular exposure of interest, I just want to understand what the rate of the outcome is occurring among a particular study population, then I would go to one of these types of queries. And we recently ran one which we posted to the website, and this is about the characteristics of gout patients. And so what we were looking for here was information about their cardiovascular morbidities and their severity, and so we brought back a bunch of information about basically their time frame before they were diagnosed with gout, so we could understand some information about them both before and after. And so you see these available to you, and just like any of the other queries, there's just as a marker, there's website links in the bottom left-hand corner of each of these slides which are available to you online, and you can check any of them out so that you can see what these reports look like and what information you get back. So now finally, moving towards getting rates. So this is where we're interested in outcomes following medical product exposures. And so when we do this, we're looking for information about time at risk and information about how many patients experience these outcomes of interest and in what time frame. And so we recently ran a query here as well, which we have posted to the website and which was utilized in an advisory committee meeting recently. And it was looking at SGLT2 inhibitors, which are a new class of anti-diabetic medications, and the rate of diabetic ketoacidosis, which is a well-known adverse event in type 1 diabetics, but has been shown to have happened in type 2 diabetics as well. And so information on this rate is available here. Again, it was used in an advisory committee to support potentially adding indications of interest for particular medical products, and this is the type of information that can be utilized when we look for an incidence rates query. So the last sort of query I'll just briefly touch on, because we'll talk about propensity scores more thoroughly later this afternoon, is a self-controlled risk interval design. So this is a situation where you're looking for an inferential query, but you're using a person as their own control. And so you're looking at a time period when you think the person is exposed to the medication of interest, and a time period you designate as unexposed, and in time you're looking for whether the rates of particular outcomes are different. And so this is an inferential query. It produces a relative risk as its outcome measure of interest, and it includes information about the number of individuals who experience this outcome during particular windows of interest. And here's the most recent use of that query with some links online. It was looking at seizures following ranolazine use. So just a really quick note that all of these slide decks, all of these sort of slides that you see, in FDA's commitment to transparency, we have all of the computer programs that we have utilized that have been vetted on what we think of as our public Git, which is located at the web address that you see here. And so you can find one, the data quality review and characterization programs that I referenced. And so this is if you had transformed the data that you have into the common data model and you wanted to see if it passed our checks. So basically if we would pass it, you can run this against that newly translated, newly formatted data and understand whether we would think it was deemed fit for purpose or not. And then these programs are the suite of the routine querying tools that I just talked about. So these are actually the medical product questions of interest. There's an extensive documentation page here with the individual packages. We'll see that later today. And then finally, we also have committed to publishing online the analytic packages. So what this is, and we'll talk a little bit more about what constitutes an analytic package, but these are the actual questions that the FDA has asked, and they are parameterized in the way that FDA has asked them. And so these are posted here for you to utilize if you had data formatted in the common data model. You can run the exact same question against a data set that you have. And so we continue to update this page. It's actually already out of date. I took this snapshot probably 2 days ago, and we just already posted another query that FDA has asked. But if you would like to know what FDA is doing, this is the best place to find that out. And so I'm going to pause here for questions, and then we're going to go to the next portion of the talk, which is to think through when you're designing a question, how you would specify it to be utilized with the tools and how you would outline it with a design diagram. And we'll talk a little bit about that in a minute. But I'll stop here and see if there's any clarifying questions or things I can answer. And I'll ask somebody to check the chat box for me and let me know if there are any questions in the webcast. And if there's a question, Margie, would you mind coming up to the microphone?
My question is on the self-controlled risk interval. Can you see the results with multiple intervals at the same time, or do you have to keep running separately?
No, you can have multiple exposure episodes, so basically windows of interest over time, as long as you meet all the qualifying criteria to enter into any given window. Okay, then I'll go ahead and move on. So what we're going to talk about here with query design is how to build your question. So how to ask it, the design diagram and the specifications. So in this morning's session, first we're going to introduce the whole concept of this through a case study. So we're going to talk about sort of, if we had a question, we're going to propose that this is the question we would have, and we're going to walk through this whole process using that case study and using training materials. For folks who are going to stay in session A, we'll go ahead and show the results of this case study in the afternoon. And for folks who are going to go to session B, they'll actually create the package to run this case study in session B in our laboratory. And so we're going to walk through this case study in two parts. The first is going to be thinking about this question just looking at medical product utilization, where we're thinking about our first steps when we start to do our feasibility analyses. And then we're going to develop an incidence rates query, which will then later support a propensity score matched analysis. So we're going to think through all those pieces. So the chosen case study that we have for you today is a completed analysis. So on the page that's titled How ARIA Analyses Have Been Used by the FDA, which you see referenced in the lower left-hand corner, there are a number of rows. And those rows indicate whence the FDA has asked a question, when we've given them a report, when they've taken that report and they have done their own regulatory determination, when they finish that, they publish to the public website an indication of how they use that information and how it helped them make their regulatory decision. So in this case, we're going to use a completed case study. So we're going to think about antipsychotic agents. We're going to look at the outcomes that the FDA was interested in, which was ischemic stroke and hemorrhagic stroke. We're going to walk through the two sets of tools that were utilized. So one is a basic utilization tool, and then another one develops a propensity score matched analysis. The results that the FDA received are shown for you there in the links for the regulatory determination. And essentially, the note here about how it was utilized, the original question came to us because FDA was thinking about a labeling change. And they were thinking about the labeling change related to the risk of stroke following antipsychotics use. And so they needed this information so they could make that regulatory determination. They ended up deciding no action was necessary, so no labeling change was needed. But that's the process that we go through in order to answer these questions of interest. So we're going to start out with our case study where we're thinking about, being in the mindset of a person who's looking for new information or new evidence about stroke risk following the new use of antipsychotics. You can see here just a list of the antipsychotics of interest divided into two categories. One is the typical antipsychotics and one is the atypical antipsychotics. So a first step always is to review the existing labels and literature to see what's actually in there. And based on the randomized controlled trials, most of the patients studied that showed a stroke risk were elderly populations and folks with evidence of dementia. And there are 3 labels that actually had a risk for that population specifically noted. And you see those pointed out here. They're all in the atypical antipsychotics category. And so when we think of Sentinel as being an evidence generation tool, we think of the regulatory questions that are asked. And so the first question relates to the fact that the existing information about the stroke risk was really limited to elderly patients with evidence of dementia. And so as in the case when any product is utilized in a wider population, the question becomes, is what we saw in the clinical trial reflective of the greater population? So when we expand out to other populations, so folks that are not elderly, folks with no evidence of dementia, do we still see that there's a stroke risk there? And then a secondary question was that stroke risk was only observed amongst atypical antipsychotics. Is there a similar risk for a related class of products, the typical antipsychotics? And so when we think about how we're going to structure our question to get information back about this, we start out with our initial feasibility. And so the very first basic question is, do we have enough exposed persons in this population? So is there enough evidence of use of the atypical and typical antipsychotics for us to proceed with asking this question to the Sentinel distributed database? And then, if we decide that that is the case, do we have enough outcome events, so these are stroke events, in this population to have an adequately powered analysis? So we're going to take these questions in turn. We're going to start out with this medical product utilization question first. And so walking through this slide that we already went over, but just thinking about it in the context of the particular question we have, we're not in a signal identification framework because we have a particular outcome of interest and we have a particular medical product. We didn't, in this case, show you how to do a summary table, but in the actual analysis, we did do a summary table, which is looking for, basically, did we have in the data set actual evidence of this use, yes or no? And so in the interest of time, we're going to just pass through that step, and we're going to go straight to the level 1 step, which is to say, we're interested in developing descriptive information about the people who utilize typical antipsychotics and atypical antipsychotics. And so for all of our exercises today, I want to say that we're going to be running these data when we do our laboratory and when we present results against a public use data set. So our Sentinel distributed data set is one that the FDA has access to and can utilize, but the one that we're going to be using for our training today is a public use data set. And so CMS, the Centers for Medicare and Medicaid Services, has a data set that they call their Data Entrepreneurs Synthetic Public Use File. And this is from 2008 to 2010, and what CMS did is they took actual patients and they blended them essentially to make synthetic patients. And they go through and they have a lot of documentation, which I've highlighted here in this screenshot for you, of how they've done this blending process. And they did it to de-identify and to prevent re-identification of these patients, because this is a publicly available data set. And so they've changed things to prevent re-identification, but they've tried to keep the richness and the structure there. So I want to emphasize that it's a data set that is helpful to us for training purposes. It's a data set that's helpful to us to practice how to use the tools, but it is not a data set that is suited for inference. And actually CMS takes a lot of pains to put that in all of their disclaimers, that they absolutely want to say that you should not try to actually create an inference off of these data. They're really intended for training or methods development only. And so as a point to that, I want to show a part of that deck. Essentially, if you go to those links, there's a long report. I pulled one table for you. It's just to show you that the information there, when they have had to do this de-identification process, has changed somewhat. So here I'm showing you, PDE stands for a prescription drug event file. So this is the drug utilization information that's available in the synthetic public use file. And it's comparing the synthetic public use file to the actual CMS file. You can see that the number of events for the synthetic public use file is very different than the actual file. It's about half, or it's a big difference. So just to emphasize that again, it's not intended for inference, it's just intended for training, but we utilize it because it's publicly available and everybody can see it. So this is the link to that publicly available formatted data. In order for the data sets to actually fit, CMS went through and they made 20 different ones. Those 20 different sets are mutually exclusive. We have transformed each of those 20 sets, and we have run our quality assurance program against that formatted data and ensured that it all passed. When you add those 20 sets together, you end up with a total data set of 2.2 million synthetic beneficiaries. So throughout our day today, we're going to be using design diagrams and specification documents as a way to communicate with folks how we're actually asking a regulatory question of interest. And this is a screenshot of a recent publication, which was a joint publication by a Pharmacoepidemiology Society and a Health Outcomes Research Society that sort of points to best practices and guidance for how we should be communicating what we're doing in observational data, and particularly in observational studies. And they call for the use of these design diagrams as a way to communicate how a study is being set up. And they also call for what we think of as our specification documents, which are very similar to what you might think of of as a protocol, where you essentially say exactly how you've created your question so that it can be easily reproduced by another individual who has that information in their own data set. And so a follow-on to this very recently is talking about that design diagram in more depth, the graphical depiction of how we're going to communicate. And we sort of ascribe to these guidances and these best practices, and we continue to incorporate them into the work that we do. Part of that transparency and part of the sort of location of where that is for any given analytic package, we always include our specification documents in the package itself. So here I have highlighted for you the question that we're actually using as our case study today. And you see here what FDA actually did to specify this question. And you can download that and you can look at it at your leisure. In it, there is a file format which I'll talk about in greater depth later, but there's a portion of it that's called the docs folder, and in the documentation folder includes that set of specifications, so you can see exactly how FDA parameterized that question of interest and utilized it to create the SAS package that was sent to the data partners. Additionally, our specifications are also used as appendices in every report we have on the website. So even if you don't want to look at the SAS package, you don't want to look through the analytic piece, but you still want to understand what was done, you can always go to the PDF report, and it's always an appendix in the end of any report that we have how that question was asked. So we're going to use a web-based interface to sort of speed us along here as we ask our drug utilization analysis question with our particular case study. So these are our questions again. I'm just going to remind, we're going to start out with step 1, where we're going to be looking at the number of exposed persons in the population. And so what kind of question are we in? This is a question for the audience. Who can tell me? We're in a type 5, so here we are all the way on the left. So we're asking a medical product utilization question only. We're looking for medical product utilization in the absence of outcomes. And so we're going to use a web-based tool that we've just started developing and experimenting with, and we'd love to get your feedback seeing it today. What this is an online platform, a web-based tool that allows the FDA to visualize, to draft, and to submit particular medical product utilization requests. It creates a CIDA package basically in the background. So essentially, the FDA enters the parameters of interest that how they want to ask their question, and in the background, a SAS package is created, which then can run against any data that's formatted into the common data model. Some question I want to make sure I say is, when can non-FDA users try it out? We're in a testing period right now. So in several months' time, after we've finished our beta testing and it's been put into production, we'll discuss with approval from the FDA how we might make it publicly available. So showing our first design diagram, we start out whenever we ask a medical product utilization question with our index dispensing or our administration. What I mean by administration is when you have to actually go to a physician's office and receive an injection or an infusion, we consider that an administration of a medication versus if you go to the pharmacy and you pick up a dispensing. So there's sort of two categories of medical products of interest. We look for particular dispensings or administrations amongst a particular cohort of interest. So that involves our cohort characteristics and our demographics. Are we looking for children? Are we looking for people who are elderly? In our case study here, we've decided we're looking for non-elderly users of this particular medication of interest. We add on some criteria about how we're going to assess this index dispensing. Are we going to use inclusion or exclusion criteria to say, this is a particular population and I want to exclude people who have some history of certain things? I'm also going to say whether I'm going to be looking for a new use of this medication. So that's an exposure incidence criteria. It's saying I want to look at the first use of this medication when I see no evidence of use in a prior period of days. And then once I have that new use medication and I have it amongst my population that I have narrowed to the demographics of interest and to the inclusion and exclusion criteria that I've set, I'm going to go ahead and I'm going to look for their exposure pattern over time. So here, this is what I was discussing before, and we'll discuss in a bit more depth, if I'm going to look at a pharmacy dispensing, I'm not just going to look at the first dispensing, but I'm going to attempt to create a treatment pattern. I'm going to see how often are people going for refills? How long do I think they're continuously exposed to this medication? And so I'm going to string that information together to create a concept of exposed time, which is a construct of having multiple either dispensings or procedure administrations of interest. Finally, I'm going to grab some information about these folks that's just descriptive, which we think of as our covariates in our evaluation window, which may later be utilized. Their baseline characteristics when they're inferential, or excuse me, when they're descriptive. When they become inferential is when they become covariates. But they're information about what the history is or what are the characteristics of these individuals who are taking this new medication of interest. So I'm going to walk through, this is our query builder, our web-based interface setup. So the first thing that we're going to show you here is the fact that in Query Builder, we have pre-specified a number of things to reduce the number of decisions the FDA has to make to get information back faster. And so there are certain things that are going to stay fixed when we ask this question. We're going to require everybody has medical and drug coverage. The reason for that is to ensure that we are capturing all the information with any exclusions or things, conditions of interest. We're going to go ahead and set the age strata right away, so we're going to divide the information out in different age groups, and we're going to keep that fixed just to ensure that we have the information covered, but there's less things that need to be decided. So the next piece that we're going to do is we're going to think about our query period, when we can expect our index exposure to occur. And we're going to go ahead and enter dates, and those dates are going to tell us when we're going to look for this use of this medication. And so we're going to fill in the information there, and this is located in our query period section. Now it's time to think about how we're going to organize our groupings of interest. So you see here that I have 22 different medications. So I could ask information about basically all of those in isolation of each other. So 22 different sort of requests. Or I can group them according to what my sort of group of interest is. And in this case, we're going to group them just by our two big categories for the purposes of training. But this was also how the FDA grouped many of their specific questions when you actually look at their actual package. And so I'm going to treat all of my typical antipsychotics together, and I'm going to treat all of my atypical antipsychotics together. And so once I've decided how I'm going to create my groupings, I'm going to create a label or a name for each cohort I'm interested in. So I'm going to ask about typical antipsychotics. I'm going to label them as such. And so this is going to be shown in these little bubbles that appear across the top of the screen. If I were to then ask about the atypical antipsychotics, I'd see another bubble there, and I'd have a different design diagram that you're seeing here that I'd have to fill out. So every time I ask a different sort of grouping, I can either clone the information I have in my current one and then repeat it, or I can ask about a new grouping. Then I'm going to specify which is my index exposure of interest. And so I'm going to put a label in there to say, so in this case, typical antipsychotics. I want to understand how people are using this. And I'm going to select whether I'm going to look for those as evidence of dispensings or as evidence of medication administrations. Now this relates to how the drug is actually utilized. So if typical antipsychotics are the types of drugs that you pick up in a pharmacy, which they are, you're going to use the dispensings category. If they're the type of drugs that you actually have to go to a doctor's office and receive an infusion or injection, you're going to use the medication administration category. So it's largely dependent on how the drug is actually utilized. And then I'm going to be able to go to a drop-down menu here where I'm going to select which generic names correspond to the index exposure of interest. And so here we've only selected 2, even though we have 12, just to make sure that we had our video end in an appropriate time. But you can imagine that we would go through and we would select all 12 in that category, or I'm sorry, excuse me, 11. And so then we're going to set enrollment criteria. Now, enrollment criteria is important in the common data model because what we want to ensure is that we are capturing information longitudinally about each patient. And so when we see the absence of something, we want to actually think it's real absence of it. We don't want to think it's just missing. And so the way that we make sure that that's the case is we look for continuous enrollment because we think most people have their information covered by their insurance company. Now, there are exceptions to that rule. There are people who pay for prescriptions out of pocket. That's not going to be captured. There are people who have other times where they're actually not medically attended. So for example, if I feel kind of ill one day and I don't see the doctor, that's not captured anywhere. And so obviously we're not going to get that type of information. But we require enrollment so that we can hope that the information in that time frame is relatively complete. So the next thing that we're going to think about is our washout period, how we're going to define the new use of treatment. So in the query tool here, the default is to prevalent use, meaning that we're not going to have any requirement for it to be new use. But there's also an ability to set a washout period to require incidence use. What a washout means is it's washing out anyone with evidence in the prior 183 days, in this case, of that same dispensing or that same medication. So basically you're saying that during that 183-day period before, I'm free of whichever the index medication of interest I'm interested in. And so what we've done here is we've shown you all those components. We've gone through and we've set our enrollment requirements, and that's important so that we can assess that time period where we're saying we want them to be free of a new medication of interest. So in this case, if I'm looking for a typical antipsychotic, I don't want to see any prior use during that 183 days. We've also set up our cohort characteristics and our demographics we're interested in. So now what it's time to do is set up the exposed time. And this is the part of thinking through our query that is the most complicated part of this morning, we'll show you. So thinking through exposed time is a 3-step process. And so I'm going to go over those 3 steps. And the first step is doing something that we call stockpiling. So what this is about is folks who get a dispensing, and then they go to the pharmacy early and they pick up their next dispensing. So when we look at a pattern, which you can see illustrated on the slide, you see overlapping periods of time, and during that overlapping period of time, they have multiple days supply, so cabinet supply you can think of. And so the question is, do we conclude that this person has 83 days of treatment or 90 days of treatment? So essentially, do we think they're saving up their medications and they're using them as directed, they're just going to the pharmacy and picking them up early? And so there is basically an option within the CIDA program to either keep those overlapping dispensings or to get rid of them. We defaulted it in the query builder to keep those overlapping dispensings, meaning that we conclude that this is a 90-day period of active treatment. And so here you see what that looks like, where we basically were sliding out those overlapping days and pushing them out to get that 90-day period. And you can see the portion there where the stockpiling has been implied. And so this is, again, in the query builder defaulted to keep all of the overlapping dispensings, but is an option in the actual program that you can throw them away if you decided you didn't want to use them. So once we've figured out our stockpiling, the second step that we have to deal with are what we think of as the gaps. Now, gaps come into play when somebody has a late refill behavior. So we say they pick up a 30-day prescription for their typical antipsychotic in this case, and then they're late to pick up their next dispensing. And so they go ahead and they wait 2 or 3 days. In this case, we're showing a 3-day wait, and then they pick it up. Do we consider them continuously exposed or treated during that time, or do we stop following them? And so here we have a tolerance that we set, and we say, okay, if you have a gap that falls under that tolerance, we're going to treat you as though you're continuously exposed to that product. And so here, the FDA chose to set a 30-day gap as their tolerance. Now, another reason why somebody may be late to pick up dispensings in the data that we see is because they've actually been hospitalized in the interim. So folks may be familiar that if you have somebody you know, or maybe you've ever been in the hospital, any medications that you've been on, your at-home medication supply is stopped, and then you're given new medications for your duration of your hospital stay, and then you go back home and you still have your cabinet supply. That might be another reason why we would see a late refill pattern. And so the gaps are designed to deal with that. Finally, we add on an extension at the end of an exposed period of time to allow us to sort of continue to treat that person as exposed, because we think they're continuing to have evidence of their at-risk time. And so the extension is often set to the exact same parameter as the gap, and we have defaulted to that in the query builder tool. It's set at 30. And so this complete treatment episode, which has these 3 steps, so again, and they're taken in this order, we do the stockpiling first, we look at the gaps second, and then if we have no other allowable gaps, we add an extension to the end. That creates a complete treatment episode of 128 days on this particular product. And so when we're filling that out in the Query Builder tool, we're going to fill out one parameter for both our gap and extension, which in this case is set to 30. So we're going to go ahead and fill that in at 30. So we could add inclusion criteria to this particular query, which we could say, I want to see that this is a population that has evidence of some condition in a prior period of time. In this case, there was no inclusion criteria, but this is a way that you might obtain an indicated population, particularly for medications that have multiple uses. So you could narrow your criteria in order to try to subset your population to people who just have evidence of a particular diagnosis of interest. Likewise, there's inclusion criteria that can be used to remove people from your study as well. And so often we remove what we think of as the opposite study drug. So if I'm thinking about comparing a typical antipsychotic and an atypical antipsychotic, I might want to remove people who are on that opposite study drug in a period before their new use of the typical antipsychotic. And so I go ahead and I enter that here. And I'm going to use the same kind of information that I used before, thinking about whether they're a drug or a dispensing or their procedure or a medical administration. And I'm going to select generic names that are associated with that opposite study drug. So I'm going to select some of the atypical antipsychotics in this case. I'm going to exclude people with information that says they had a dispensing of that in that 183-day period of time. Now, recall that the other thing the FDA was interested in here was dementia. They wanted to see evidence of a population that did not suffer from dementia, because the information that was already available to them in the label was about elderly people with evidence of dementia. So here we can exclude people who have evidence of dementia in a particular pre-specified period of time. And we're going to do that using an algorithm that comes from CMS, which is called the Chronic Conditions Warehouse. And so the Chronic Conditions Warehouse is a set of 27 conditions, and those conditions have different ICD-9 and 10 diagnosis codes associated with them. And so we use those code lists in this particular tool to specify a particular chronic condition. Now, the CMS algorithm specifies longer periods of look-back time than what we have available here. Here we let the user specify whatever they would like. So in this case, 183 days is specified. Now in the actual algorithm that CMS suggests, they often suggest a 365-day look-back period or a 730-day look-back period. So I want to emphasize that while we use the code lists, we don't use the exact algorithm because we allow individuals who are the requesters to ask what period of time they want to see evidence of this particular chronic condition. And then finally, the last component we have available in the query tool is a pre-specified covariate table. And so this is just, again, information about a particular cohort. It's showing the prevalence of particular chronic conditions in a period of time before they have an incident dispensing of, in this case, our typical antipsychotic. And so we're going to look for that in the prior 183 days, and we're going to specify that here. So altogether, what we have done so far is we've created our design diagram, which is now shown here in a different format and filled out for you. So the way to sort of think about this is our anchor here is our index dispensing, which we're looking for a typical antipsychotic dispensing. We're going to go ahead and say that we want to see new use of that dispensing, which means we don't want to have any evidence of that in the prior 183 days. We're going to require enrollment during that time so we can actually assess that, in fact, we have no evidence of use of that during that time. We're going to also exclude people with evidence of dementia in that same period of time and on the day of their index dispensing. We're going to look for some information about baseline characteristics of these individuals during that same 6-month period of time. We're going to only look for folks that are non-elderly in this case, because in our use case here, we already are decided we're investigating folks particularly who are non-elderly, and we're also going to look at adults only. We're not going to restrict either our sex characteristics or our race characteristics, and we're going to follow a patient for the lifetime of information they have in our database. When we construct our treatment episodes, we're going to go ahead and we're going to say that we're going to have stockpiling where we keep all of our overlapping dispensings, and we're going to allow a 30-day tolerance for if there's a gap in sort of treatment time. All of this together allows us to sort of say what we're doing and to be very transparent about how we're asking our question. And so now we're going to show you what the report looks like using our synthetic public use file data. With, again, a disclaimer reminder, this is synthetic data. So we're not actually going to think about it like it's a real study. We're just walking through this for the purposes of training. And so when you use the query builder, we export a design diagram per scenario. We also will export something like our specifications table. This is what our actual specifications look like. We're working on our format for exporting now, but you will always get these two components. Again, the main objective here is the transparency and the ability to reproduce what was actually done. So this is what a baseline table looks like. And so we're going to walk through this, and having done this query, because again, what Query Builder does is it's a web-based interface that creates a CIDA package. And then that CIDA package is executed against data in the common data model. And so here we're going to look at, on the left, our typical antipsychotic users, and on the right are atypical antipsychotic users. And you can see that there are approximately 10,000 more typical than atypical users, and you can look at the mean age, again, in the synthetic public use file, which is a CMS-derived file, so the mean age is kind of higher at 71 in terms of the people who are the users of these drugs. You see an age breakdown, you see a gender breakdown, you see a race breakdown, and you see a year breakdown, and that year is the year of the incident exposure. So recall that the CMS data, the training data set runs from 2008 to 2010, which is why you see the percentages there. What you might conclude if this were real data, but again, I'm going to emphasize this is synthetic data, is that these two cohorts are very comparable at baseline without any further adjustment. We're going to also look at the the chronic conditions warehouse conditions, which are going to be standard output for this particular piece. So on our left, we have our typical antipsychotics users, and on our right, we have our atypical antipsychotics users. I'm going to draw your attention to a couple of these chronic conditions that may be of interest. The first part is just showing that our exclusion worked, which is what you would like. If you exclude people with history of dementia, you'd like to see that, in fact, in that 183 days, your exclusion worked and you don't see anybody with dementia. You might also wonder about the indicated population, and so I've highlighted a box for you around depression, because you may think that typical or atypical antipsychotic users may be suffering from depression. You might want to understand who has evidence of that in their record in that 183-day period prior to their new use. And then finally, at the end, I've highlighted for you evidence of a stroke or a transient ischemic attack in that baseline period. And that may be of interest to you because you may be deciding whether you are going to wash out people so that they have no history of stroke for your particular question of interest, or you might want to enrich your population and see how many people are at higher risk for those outcomes because they've had evidence of a prior outcome. So this is going to give you information on that. And so as you're looking through this, I'll tell you that, again, it's synthetic data, it's just for the purposes of training, but when you're looking through this, you would look to these two groups and you would be thinking, are they comparable? If I'm going to set up for doing an analysis, is it appropriate to compare these two populations? And so you're also going to get some descriptive statistics back on the treatment episodes. So the first table at the top describes the cumulative exposure on a patient basis for the lifetime of information we have in the data set. That middle table is going to talk about their first treatment episode, so their first episode of continuous treatment. The last table you see in this group of three is going to talk about all their treatment episodes over their lifetime. And so that's why they have some different numbers in terms of what they're describing. So you see here that in the data set that we have, which keep in mind is only 3 years long, we have only a few people who have multiple treatment episodes. So we have just sort of a small proportion that are able to fit in more than one treatment episode during that time. So now what I'm going to highlight over here is the total days of duration of that episode. And so you see that the maximum amongst the patients themselves over their lifetime is obviously larger than their individual treatment episodes, and that comes from people who have multiples. We're also going to grab information about the descriptive statistics related to the number of dispensings they have and the days supply per dispensing. And so I want to draw your attention here to what is known as the interquartile range of the information about the dispensings. And you see here that the interquartile range shows that the dispensings are largely 30-day dispensings. So somebody's going to go and they're going to get a dispensing for 30 days. That's important because as you look up, you see the interquartile range for the duration of their treatment episode. And so we know that primarily people are picking up a 30-day dispensing, and we're seeing from them a 60-day treatment episode. And so what that actually is happening is, do you recall that we added a 30-day gap or extension onto the end of each dispensing? So what this pattern is telling us is that most people are picking up their first 30-day dispensing, and they're actually not getting a second dispensing. And then we're adding that 30-day gap or extension that we've said we're going to add on to create a total treatment episode of 60 days. So why this is important is, with these data, we can discern the treatment pattern that we're going to see amongst these individuals when we think about asking these regulatory questions. And then finally, we have some information about the gaps or the time frame that occurs between treatment episodes. And you can see right here where the interquartile range of these gap numbers is very long. So basically, people are having a first episode, and then they have a very long time between either they have a second episode or we stop following them because we've hit the end of our sort of 3-year time frame of our study set here. So all of this is available to any user who runs this type of report. So this is what I'm talking about when I'm saying these are our standardized outputs. So we also have censoring information. It says why we're going to stop following individuals, and we do it on an episode basis, and then we have all the episodes aggregated together. You can see that most of the reason that we stop following these people is what we think of as episode end, or we call that treatment cessation. So essentially, they picked up a dispensing, they didn't pick up a subsequent one, we stop following them. That's where they're lost to follow up. We have very little disenrollment or evidence of death in this particular group. We also bring back attrition data, and I'm not showing it for you here because it's a rather long table, but I want to sort of let you know that when we see the attrition data, we see losses for a couple of reasons. Our very first reason is that people don't have the required enrollment. So we lose them because they don't have evidence that we can follow them for a particular period of time. Our second group of losses are demographic. So in this case, we asked for particular groups of people, and we lose them when we limit those demographics to those groups. Our third set of losses are the lack of having the actual index-defining exposure, which in this case is typical antipsychotics. So essentially, we lose people from the database because they have no evidence of a typical antipsychotic, and then we don't follow them. And then the final set of losses are really query dependent. They relate to the inclusion or the exclusion criteria for particular queries, and they relate to the washout period as well. So medical product utilization query takeaways. First, again, this is synthetic data. But if it were real, and I was thinking about this in terms of setting up for further study, I learned that my cohorts were comparable at baseline. I learned about that treatment pattern, so I could see that people were getting a single dispensing and then having an extension, and therefore were creating a 60-day period where they were considered at risk during that treatment episode. And I learned about my sample size. I know how many patients I have, and I know how I'm going to potentially lose them if I make any further cuts. So if I'm going to engage in a one-to-one match, recall I had about 10,000 more patients in my typical antipsychotics group than my atypical. In a one-to-one match, I'm going to lose those 10,000 extras. Additionally, I'm going to lose potential people if I decide to exclude those with a history of stroke. So this is a design decision going into an inferential query. Do I want to have my patient population enriched with a group who's likely at higher risk of stroke, or do I want to remove them and use restrictions so I have a different population I'm looking at? Now I have an ability to estimate what that population looks like. So I just want to talk a little bit about the differences between what I've shown you here, which is the web-based interface, and which we think of as a simplified version of our CIDA tool. In the query builder, we have the demographics, the enrollment criteria, and the baseline table concepts all fixed. So essentially, there are no further decisions to make there. Our exposures are based on generic names instead of codes. So when we use CIDA proper, we look for very particular codes. Here, we've basically created a map of codes to generic names. So you just select the generic name you want. Sometimes it doesn't work out so well. So for example, oral birth control is one where the generic name is very nonspecific. And so you may or may not be able to do something of interest in that particular category. The inclusion and the exclusion clinical concepts here are based on the chronic conditions warehouse. Our later versions of this tool will allow a complete code upload. And exposure can't be truncated on a user-defined sort of set of things that happen, which we can do in our larger CIDA process. The idea here is that this specification process is intended to be simplified. It's sort of your first entry point into using the system, and then you can go on to create more complicated, complex queries using SAS, if you're familiar with it, later when you are doing your inferential question of interest. And so with that, I'm going to pause, and then I'm going to tell you that we have a coffee break scheduled where we can actually also order our lunch if we have not yet ordered it. And also, if anybody has a question that they'd like to not ask publicly but want to come up to me during the coffee break, I'm available at that time. But we're going to stop now and see if anybody has any questions before we continue on. Go ahead. Can you go to the mic, please?
I'm Christina Green. I'm an epidemiologist with the FDA. I was wondering if, when you're building the query, because you mentioned the 27 chronic conditions, there's also an other set of chronic conditions. Are those available for use as well?
So the chronic conditions warehouse is basically the CMS code list.
Yes.
If you want to use the more complex tool, you can have any chronic condition you want in any way you define it. It's in the simplified tool, we're limited to the 27.
Oh, okay, I got you. Thank you.
Mm-hmm.
I'm Wojciech Kieser, NIH. You went quickly over the export capability, and you said we're building on the export, and you showed an Excel export. Can you describe more the current export and describe more the future export?
So in the query builder design, there's an export for the picture, right, the PNG, and then there'll be an exported table which is going to have the specifications in it. Right now, I'm showing you the specifications document we often share with the FDA, which is in Excel, and also the ones that you will find in the PDF versions of the reports that are available online. So those are always shown in Excel, even though we convert them to PDF. But the one that's going to be exported from the tool is just going to be an ASCII table. It could be, it's not necessarily Excel per se.
I mean, something like JSON?
Well, we'll talk through sort of what are the possibilities of export.
Because if I understand correct, it just needs to save whatever I entered into the
That's
form.
exactly right.
So it's not very earth-shaking.
That's right. And so it's going to be dependent on what the FDA would most utilize.
You mentioned earlier the availability of the ETL2 for the market scan database. Suppose you have 10 years market scan data, I think how long will it take you to basically convert data to the common data model?
That's a great question. And actually, so we have our 100% market scan data is 130 million, and we have data that ranges quite that long. And so we run it on a Linux server, and so basically depending on what sort of server that you have and what your capabilities are is how quickly it runs. Actually, I'm looking at an individual right in the front row who's very recently transformed his data. I hope you don't mind if I mention Carl, that he did it in 48 hours, and the query ran overnight, so it wasn't very difficult at all. Any other questions before coffee? Thank you for your attention this morning. I'll be happy to see you after the coffee break, and I'll be happy to take any questions. Thank you so much.